Thank you very much, everybody, for joining our webinar this afternoon, this evening, and tonight, and overseas early in the next morning. This is part of a session that is this week on Thursday is World NTD Day, and so there's going to be events all throughout the world on neglected tropical diseases and bringing awareness to these devastating diseases. So tonight, my name is Kishore Wasan. I'm the co-founder of the Neglected Global Diseases Initiative. And tonight is the first event of a new series called Real Stories from the Front Lines, Universities and Global Citizens, being hosted and held throughout the spring by Green College here at the University of British Columbia. So we want to thank Green College very much for their support and their help with this first session tonight. So the webinar, which we are co-sponsoring at the Neglected Global Diseases Initiative, will highlight how Canadian drug development can transform medical care for neglected diseases in humanitarian crises. And one of our speakers will be Dr. Jason Nickerson, who's the Humanitarian Representative to Doctors Without Borders, Canadian Doctors Without Borders. And I believe he also has an appointment at the University of Ottawa and in Rwanda. And actually, he is in Rwanda right now on the ground, is our co-director of NGDI and Associate Professor of Medicine and Infectious Disease, Dr. Richard Lester. Each of these presentations will highlight the importance of working with partners in countries where these diseases arise and to track and to monitor the progress being done to address these types of diseases. So join us for the conversation on global health citizenship, ethical partnership, and the future of university engagement in tackling the world's greatest and biggest challenges. Now, to begin, to get us started, I'm going to share with you just a few, let's go ahead here and get this shared up here. I hope everyone can see that. What I'd like to share with everybody is a few things about neglected global diseases. And let me click this so I can see them. So what are neglected global diseases? These are neglected tropical diseases. And it's something very interesting that Pope Francis said when he came to Edmonton a few years ago. He said that the opposite of love is actually not hate, but indifference. And I think that phrase stuck with many of us because that is really what neglected tropical diseases are. These are 21 infectious diseases which increase poverty and occur in the poorest regions of the world, often tropical areas, war zones, and remote areas. Though I have to tell you, because of climate change, some of these diseases are now washing up on our shores here in North America and places in the world that you wouldn't expect. They affect over 1 billion people, so at least 1/8 of the world, though I think that number is actually underreported, and we may be close to 2 billion people that are inflicted with these kinds of diseases, especially women and children are neglected because they have limited funding, research, and treatments available, and no profit is made. So the question might be, ladies and gentlemen, why are they neglected? It is because the proportionality between the magnitude of the disease, how widespread it is, and the millions and billions of people that are being inflicted by these diseases, and the resources that we have to treat those diseases is completely out of balance. And that's why they're neglected. And we need to find resources, money, infrastructure, support to be able to treat these diseases. So the question that really has come up that really got NGDI started, and is really some of the talk that Green College would like us to focus on, is how can the poorest of the poor share in university discoveries? How can we actually translate the great work that's being done at our universities, that's being done with humanitarian organizations like Doctors Without Borders, and get it so that they are on the ground, that make a difference in people's lives, that they translate to new standards of care. It's great to have these kinds of new types of things, techniques, technologies, and so on in our universities, but how do we be able to translate that where it makes a difference in people's lives and actually improves their standard of care? And so that is something that at UBC, we are very much at a mission of. And this is a recent poster which turned into a publication in Frontiers in Pharmacology that was published by Dr. Nancy Galini and the group of us at NGDI, talking about some of the global access principles and equity that we follow at UBC and some of the projects that are ongoing at our university to try to translate the great work we're doing to make a difference in these places around the world. So with that as a beginning, I'm now going to turn it over to Fahan, who's going to now load up Dr. Richard Lester's talk. Richard, as I said, is an associate professor and the co-founder of NGDI. Rich was not able to make us live, but he was able to record this presentation because he was actually called away to Rwanda, and I think he lands in Rwanda at like 7 o'clock this evening, Vancouver time. So really on the ground right now. So with that, I'm going to have Fahan go ahead and cue up Rich's talk. So over to you, Fahan.
This is Dr. Richard Lester, Division of Infectious Disease. My pleasure to be presenting to you today with Green College and stories from the front line. Unfortunately, I've had to, get to travel for field work to Rwanda, so I'm en route, so I'm having to pre-record this. If there are questions, I'm in the air on WhatsApp. I'm able to do some questions via my colleague via Fanan, so I hope that can work. Just first disclosures, again, I'm a physician of research from a number of sources which are disclosed here. Some of them are private foundations and components from pharmaceutical companies all come through UBC or to our also founder of nonprofit and also company WellTel Incorporated, which is provides digital health services focused on equity globally. So what is equity in healthcare? And I took this one timely from Ask ChatGPT, and they say it's healthcare refers to the principle of ensuring fair and just access to healthcare services, opportunities for all individuals, regardless of their social, cultural, or geographic circumstances. Focus on eliminating disparities in health outcomes and addressing barriers that certain groups or individuals are achieving. So what is global access? And to be fair, I've been to Google's AI source to ask, and from Gemini, and global access is healthcare refers to the ability of all people, regardless of their location, socioeconomic status, again, and other factors to obtain health services. So access and equity are quite linked, as you can see. Where did I get my start? So since I was a kid, wanted to do medicine. I wanted to go to Africa, grew up in Smithers in northern BC, and finally got my chance to do my postdoctoral research fellowship. I joined Dr. Frank Plummer, Dr. Frank Plummer's research group, which was doing groundbreaking work on HIV in Kenya among female commercial sex worker groups, and found that there was a group that was resistant. So I thought I was going to have a basic science career. I was interested in toll-like receptor signaling. We wanted to help with a vaccine. Hopefully, I could help other people be immune to HIV infection. Things changed a bit when opportunities come, and the great need of the time was, although the HIV global burden was heaviest in very low income countries, and you can see the dark bars on the left are low-income countries, often in Africa. But the global response for providing treatment through the US PEPFAR program and then the Global Fund actually did meet some of the demands, ultimately met a lot of the demands, treating people equitably, even in resource-limited countries. There was another, let's say, revolution happening at the same time, and that was the wireless or cell phone revolution. And you can see the dark bars are actually that cell phone uptake is actually highest in resource limited or developing countries at the time. So this was an opportunity where we had a novel way of communication being distributed in the world, and how that could potentially be used in healthcare. So I asked the question, how could mobile phone communication help the treatment burden and demand for HIV infection, which was the pandemic at its crisis. And there was concern about drug resistance. People fell out of care. So we came up with a program in text messaging, simple mobile phones in 2004, 2005. And it was the first in the world trial. I had the benefit of my mentors to do a large randomized trial with text messaging to check in on to see if they could improve HIV treatment. And fortunately, it did. We ultimately published in the Lancet and found that those getting text message weekly check-ins on how they're doing were more likely to be adherent to the medication and detectable viral load in the year. So this started the whole process thinking how can we use mobile phones to improve healthcare for HIV to scale, but also for other conditions or any condition. And part of that was through research, and then part of that is through creating products and services. So we did get into implementation science for a while, because to go from patient-centered approach to improved clinical outcomes is a large, complex journey. We were able to publish about this this approach that we did. To a lot of our colleagues thought texting reminders would be the key to improving treatment adherence. However, it's actually we found that the short of asking patients how they are through text message was more successful. And this led to a large research program where we developed more and more studies on how to use mobile phones in what scenarios and different health conditions around the world to connect directly with patients in the convenience and also in an effective way to improve health outcomes. But equity and access are very important in this. If we were to use mobile apps with internet, a lot of countries, lower middle income countries, less than 50% of the population have internet access. So they're automatically cutting off some of the most vulnerable groups. So we focused on text messaging and shared phone use, which could reach often over 90% of the population, even in resource poor. We also looked at gender and actually found that the gender gap was not wide when we were using this approach of check-in for HIV, and that women were actually accessing it just as high or even higher than men through the original study. But we did actually a study in Vancouver General Hospital as well, but back here in Vancouver, and actually found among elderly patients and so on, text messaging still had a larger reach than applications and apps, and also less barriers because you don't need passwords and other things that can be a barrier to even get started for many. Then, of course, let's go forward a number of pandemics. Worked through SARS pandemic, H1N1, and then, of course, the most recent COVID-19 pandemic really changed the world of digital health quite a lot and made virtual care actually much more acceptable, where patients could follow up with, contact their doctors by phone or video and be followed up as well. So the comfort of that actually changed. It's one of the silver linings of an otherwise horrible pandemic that had a lot of burden, but hopefully some lessons learned as well. And we had, fortunately, our technology, because it was already available for connecting healthcare workers with large numbers of patients more efficiently and through simple text messaging and/or an application, it had some utility world. So we did a landscape. We got funded by the CIHR in its initial urgent funding round for the pandemic, and did a rapid landscape review of technologies. But ultimately, we were able to show that connecting with people via their mobile phones could be an effective way to stay in touch. We had projects here in Vancouver, again, BC Children's cardiac transplant patients up in Haida Gwaii primary care were using the program already. So they ramped up and started texting. And a lot of the kids very vulnerable who, if they don't take the medications for heart transplant, they could reject. And of course, of that outcome, found that just being connected by the mobile phone was enough to help them transition through care and stay engaged and take their medication. But with the pandemic, the other opportunity, as it became widespread, was to text large numbers of patients, so cases of COVID, who could be supported at home through text messaging check-ins. One, to see if they have symptoms worsening, do they need to be triaged to improve hospital or care, but also provide them the support, because it's two-way messaging. You can also provide advice via text message or go to phone or video if needed. We started building all of those virtual care elements into our platform. And this is again from the cardiology patients usage. And in Africa, there were a number of innovations happening. And we had the fortune of working now in Rwanda with the Rwanda Ministry of Health, and they looked at, again, a way to reach out to their patients, adopted their health program early in the first days. It's the first cases were coming with COVID into the country, and it remained the backbone of communication in the COVID home-based care program throughout the pandemic. And Rwanda did really a remarkable job in monitoring, supporting the pandemic, the COVID-19 for the country as well. And you can see we've published a report of how it was used there. So now I'm going to jump forward again. And what about AI? We're in the next era. So the first step was just being in touch with patients and how powerful that could be in the convenience with wireless phones and connectivity. But now we're in a new era. So what's happening? So the University of British Columbia has an initiative called Data Science and Health, and you can look that online. There's some webinars, seminars, courses even that can help people get started in the area of understanding data science and healthcare. And from us, just listening to your patient is telling you the diagnosis, really goes back to some of the origins of medicine. Since we're using modern tools, what can we learn from these? So we started a program back in 2017 called Smart Text Analytic Tools, and then we built a dashboard called Convoscope that can analyze the text messaging conversations anonymously too, or without aggregate data with the public health, personal health information, and give us insights into the populations that are being monitored. What are the needs they're having when they're being monitored and supported? I don't like to use the word monitored alone. It's really the support that matters to patients, to access the care that they get. What kinds of support are they getting? Is it symptom management? Is it psychosocial stressors? We mentioned in health equity and access that social stressors are often a key component. So we were able to take these conversations and now use modern natural language processing tools, and we trained them also for Kinyarwanda, so other language, that means machine translation. And we were able to demonstrate in our new dashboard how to analyze these methods that could give insight ultimately on some of the best ways to present to respond to crises and pandemics, potentially in real time as these. And there's some work by another colleague at UBC from Dr. Mohamed Abdelmagid. There's some incredible work in machine language translation, and did some work in COVID globally with very, very extremely large data sets in billions and hundreds of languages to try to detect what people were talking about on Twitter during the pandemic as well, and misinformation and so on. So real opportunities for health equity when you can dive down into resource and limited languages. One of my favorite coffee shops and places in Kigali in Vancouver, on my way there now. It's a wonderful city. It's a country that's gone through some very trying times, as you know, but it's really making a move forward in healthcare and innovation. There's a lot of collaborative opportunities. And they had the Health Tech Summit last year, where AI in healthcare is really forefront in the agenda to improve healthcare. And of course, access. So Canada, of course, focuses on health equity as long as we can preserve its written health to try to ensure that people at least have the financial means to access healthcare. And the UBC has taken a key role with this is on behalf of NGDI. When I first became involved with them, was really impressed with the global access principles at UBC, which actually got a ranking very high compared to other global universities, Oxford, Harvard. The UBC Global Access Principle are really ground setting for principles that if innovations were developed through universities in resource centers Nancy Guini, who's been a key member of the NGDI board, and Kish Vasson, Bob Hancock, and Brett Sharp are all playing advocacy roles in access. So, and in fact, we have an upcoming webinar, which hopefully you'll be able to attend in March, a workshop that's going to focus on those of you very interested in university institutionalized guidance and for access and equity coming up in March, where we're hoping that these principles can really spread throughout Canada, throughout the world, and we saw from COVID a lot of inequity again in vaccine distribution. So there's a lot of work to be done. And I think if we come together with these policies, which are really make sense, we can hopefully be in a better place in some of the next. Doesn't seem like the next pandemics, the next outbreaks are far away. It was just work in the Marburg outbreak in Rwanda recently, which was really well managed. But it just seems like the next one's always around the corner. So we need to keep this lens of health access and equity. I just want to say thank you very much. It's been a pleasure. Wish I could be there in person. Happy to answer any questions.
Well, thank you, colleagues, for your patience. Sorry for a little bit of the audio issues. Rich was actually at the airport as he was moving through to Rwanda. He's actually landing there. I think he'll probably be there in the next half an hour. So he's right on the ground. If there are questions or comments or so on, you are welcome to send it to Fahan and I privately, and we'll make sure that Rich gets them and he'll respond. We will also put this on YouTube as well, so that if you had a hard time hearing some of the things, we can go from there. So thank you, Fahan, for coordinating that, and of course, thank you, Rich, very much for doing that. So next, I'd like to turn to our second speaker, Dr. Jason Nickerson. And Jason, hopefully you'll have the ability to share your slides if you have any. And as you know, Jason is in the humanitarian, one of the humanitarian crisis leads for Doctors Without Borders in Canada, and has also got an appointment at University of Ottawa. And Jason has been a big advocate and supporter of what we're doing at NGDI and at UBC, but also with the Canadian Network for Neglected Tropical Diseases. And I see Tina Lyons is on there from CNNTD, and CNNTD is just an amazing organization. If you haven't checked their website out, or what the amazing work that they're doing, because they take it at a Canadian lens and help us connect each other around Canada to the world about the kind of work we're doing. So without, over to you, Jason, and we look forward to your presentation. Thank you so much.
Great. Thanks very much, Kish. Just want to confirm you can see slides.
I can see them. I think everyone can see them. Go for it.
Okay, great. Cool. Thanks, everybody. Nice to be here. I did my master's at UBC and worked at St. Paul's, so I know I know the setup very well. So I'm the humanitarian representative to Canada for Doctors Without Borders. I also have a clinical research appointment at the Briere Health Research Institute. So my research focuses mostly on uh, acutely and critically ill older adults, particularly in humanitarian emergencies and public health emergencies. And then I do some research related to health law, policy, and ethics as well. So I'm appointed as a law professor, but that's a bit of a weird place for me to end up. But it all makes sense in some way. And so as the humanitarian representative to Canada. So I'm the sort of the diplomatic representative here for MSF. So my role is to engage with governments, the diplomatic community, civil society, and so on a range of issues that matter to MSF. And yeah, to work to find sort of meaningful solutions for our patients in the field. Um, so just in conflicts of interest, I'm obviously an employee of MSF. I don't receive any kind of industry funding and haven't over the last more than 10 years. I do have some CIHR funding for some projects that are not really related to what I'm going to talk to you about today. Um, all right. So, Doctors Without Borders, we're a private charity. So we're a medical humanitarian organization. We've got 30 offices around the world, but we work in 70 to 75 countries that are affected by armed conflicts, natural disasters, disease outbreaks, and so on. We really are an emergency organization, so we focus very heavily on being in really some of the most difficult places around the world. And we're quite specialized in negotiating access to reach populations and communities in distress. We're actually a pretty large organization. So we have operating expenditures. We're a little bit higher than the number that's here in 2024. We're around 2.45 billion euros in terms of expenditures. We've got 60,000 staff. And as I say, we're working in anywhere from sort of 70 to 75 countries at any given moment. The vast majority of our staff are locally hired staff. We do have significant internationally mobile staff, so international staff complement, including several Canadians at any given time. We have, we're sending on average about one Canadian to the field per day. And those can be specialists from, sort of the medical side of the house through to logisticians and emergency managers, project coordinators, that sort of thing. And then you can see sort of the operational footprint on the left here. We're doing 16.4 million outpatient consultations, more than 1 million inpatient admissions, and multiple million measles vaccinations, and so on. So our medical footprint is very high in the places where we work, and we're an organization that has structured ourselves around principles of humanitarian principles that are embodied in international humanitarian law, which is sort of the governing legal framework in the places where we work. It's the legal framework that allows us to have access to populations in distress, and that requires parties to a conflict to ensure that patients are able to reach us. So we're an organization that operates impartially. We work to assist people who are in need, regardless of any kind of race, religion, political belief, anything like that. We're also independent. I mentioned, we have a pretty large budget. We're almost entirely independently funded, so we're at about 98% privately funded, with a donor base of around 7 million independent individual donors. So we're not a government-funded entity. We only have 3 government donors that we accept small amounts of funding from. The Canadian government happens to be one of them. But an independent financial model allows us to react very quickly, and also to be in places, on the basis of need. and to not have to wait for funding cycles and that sort of thing. So it's a big part of how we actually negotiate access is by sort of asserting this independence and making it into something that's very practical and operational. Also, as an organization that works in armed conflicts, we're neutral. So, humanitarian assistance doesn't favor any one party to a conflict. We really do operate on the basis of needs and needs alone. The kind of humanitarian response that we can mount, really it's responding to a break in equilibrium is how I think of it. About 50 to 60% of our programs are in places of armed conflict or some sort of internal instability, so a situation of violence. Also, we're responding to sudden onset disasters, things like earthquakes and hurricanes and flooding and that sort of thing. We also have a very significant outbreak response capacity. So the vast majority of disease outbreaks that we're responding to on a day-to-day basis are not the kind of things that tend to capture front page news in Canada, but rather are measles, cholera, pertussis, that sort of thing. And often those are very significant outbreaks in the places where we work, come with significant morbidity and mortality associated with them. And we live in a reality of an inadequate and public health response to most of the disease outbreaks, which is very much in line with what Kish was saying with regard to neglected tropical diseases, and something I'll talk about a bit more. As a medical organization, we do, in a sense, think of ourselves, I would say, as an academic kind of medical organization. So, we're involved in operational research. We're constantly challenging models of care. We're constantly pushing the boundaries of what's possible to deliver in terms of high quality patient care under very difficult field circumstances. So, some of the more recent updates to things like drug-resistant tuberculosis guidelines are updated as a result of research that our organization has funded and carried out, looking at how to shorten treatment timelines and sort of make things less complicated, which is an operational prerogative when you're working in a very complex and volatile environment. But the point is really, we're constantly trying to push the boundaries of what we can do and how to bring in new technologies, new medications, and new care pathways to improve the kind of quality of care that we're able to provide. We're also working within a framework of what we would call témoignage, or bearing witness to suffering. Um, this is there's a slight deviation here in terms of how you do that while also being a principled organization. But the point is that we speak about what it is that we see, and we feel that we have an ethical and a moral obligation to speak out, and to be, first of all, in constant dialogue with authorities and warring parties and organizations. So we reach populations in distress through negotiation. We don't use armed escorts or, military protection or anything. Where the places where we are able to be is by virtue of negotiated access, and an acceptance of our presence. So that involves a lot of talking and negotiating. But we always reserve the right to speak out publicly and to bring visibility to a forgotten crisis, or to, speak out about an abuse or an inadequacy of a humanitarian response, and to call out, policies that are harming people or restricting access and so on. And a part of that, is very much embedded in the medical advocacy work that we do. So we've had an access campaign, which is now going through a restructuring, but we continue to invest and are scaling back up our work on improving access to medicines, vaccines, medical devices, diagnostic testing, and so on. And we're also a co-founder of something called the Drugs for Neglected Diseases Initiative, or DNDI, which is a not-for-profit pharmaceutical company or research organization that's successfully brought new treatments to market for neglected diseases. And so, bringing it back to the medical R&D space, we're a medical organization that purchases medicines, vaccines, and devices. We almost universally have a policy of not accepting donations. The reason for that is that donations in almost always come with strings attached to them. Who you can use a given donated product or medicine or vaccine for, where you can use it, where you can't. For an organization doing 16 million outpatient consultations per year, that makes life far too complicated. Our approach is very much to negotiate fair prices on an international market, and we think that that's, in a sense, a public service that we're capable to provide, is to try and negotiate down the price of new medicines. And so we are an organization that needs affordable prices, but we also need innovation in the pharmaceutical space for diseases that are affecting our patients. And so as a part of that, it's one thing to be sort of a purchaser and a negotiator of medical technologies that already exist and, are off patent and exist in a fairly vibrant kind of internationalized marketplace. It's another thing when we're talking about, new medicines that are either coming to market or working their way through the R&D pipeline. And so we're very much in a place of trying to examine what the role of our organization is in pushing for more equitable and principle-based innovation that can drive more investment and development in neglected disease areas, but also, really trying to work with innovators, including universities and, public and private sector entities to facilitate fair licensing terms that can secure and facilitate access to new medicines when they come on the market. And I'll talk a little bit more about that in a second here. So I'm just going to sort of walk you through a bit of a story of how we came to this. There's effectively a global market failure in the development of many medical countermeasures. So things like vaccines, therapeutics, diagnostic tests, for a lot of high impact pathogens. So Ebola is a very prime example of this. There's an Ebola vaccine that I'll talk about a bit more. There's 2 therapeutics that are approved with really only one randomized controlled trial with pretty limited data. We've got stockpiles of many of these things. But by and large, there's a market failure in this space. Canada is a significant player, or at least could be a significant player, but is really not fully stepping up to the plate and getting a lot of the very useful technologies that are being discovered all the way through the pipeline and into the marketplace where they're really needed. And the sort of prime example of this, really for us, and this is the start of at least the MSF Canada kind of foray into medical R&D work, came from the Ebola outbreak in West Africa in 2014 to 2016. It's an outbreak that really started in December of 2013, but was first notified on March 23rd, 2014 by the Ghanaian Ministry of Health. It was the first Ebola virus disease outbreak that was outside of Central Africa. I'm sure everybody on the call remembers this really horrific event with 28,000 cases and more than 11,000 deaths. This signaled so many things, I think, to the global health community. The first is like the impact of this outbreak was massive, well beyond the toll from Ebola virus disease itself. There was a massive impact on local economies. There were massive economic and social impacts that certainly went into the tens of billions of dollars. Really reversed a lot of the progress from the Sustainable Development Goals, and much more. And so with this outbreak, it became very clear several months in, really by August, that the outbreak was out of control. And we were saying this publicly and very openly at that time, that things were spiraling out of control. The response was chaotic. It was inappropriately resourced. There was very little experience in managing Ebola virus disease outbreaks among many of the responders that were on the ground. And so it was an outbreak that was caused by the Ebola Zaire species, or the Zaire species of the Ebola virus, which is the most common species. There's others, including Ebola Sudan. There was an outbreak of Ebola Sudan in Uganda 2 years ago. And most Ebola outbreaks in the past have been contained through the use of non-pharmaceutical public health measures. So, good contact tracing, infection prevention and control measures in hospitals, and so on. And we now have 6 pillars as a result of the West Africa outbreak, that are really non-pharmaceutical in nature, but the scope and scale of this outbreak really increased the urgency of vaccine research and development. And so by summer, late or early fall, the international community was really pushing to try and understand where are the vaccine candidates that have effectively been dormant, and how do we get them to the finish line? And this is where it became clear that Canada was actually a pretty significant leader in this space. The National Microbiology Lab in Winnipeg started working on an Ebola vaccine in 1999. Really with the recruitment of one particular researcher into the special pathogens division there, and they were successful. They found a vaccine, or discovered a vaccine candidate, and filed a patent for it in 2002. That's the RVSV-ZBOV vaccine. And they continued work on it for actually a number of years, until they ultimately transferred the rights out from the National Microbiology Lab to a pharmaceutical company called Bioprotection Systems, which is now NewLink, as a result of mergers and acquisitions as things go. But really, the National Microbiology Lab was doing a tremendous amount of work on this, and continued to do a lot of R&D work on the vaccine, even after the transfer of rights out. And so, really, as the outbreak was raging, the urgency of getting this vaccine or another vaccine to the finish line was top priority. And it became very clear that the Canadian vaccine, despite being discovered 15 years earlier, was really just sitting on a shelf. It had never been developed further. The license was signed, as I say, in 2010. The negotiations for that actually started in 2008. And in the license, between the Canadian government and the company had specifically pledged to use, quote, commercially reasonable efforts to develop the vaccine. But actually nothing happened until October 2014. And so there's pretty significant public pressure as the pieces started to come together. And as you can see here, this is an article from The Lancet that was really one of the tipping points. I happen to be the second author on this paper. And we were successful in putting public pressure toward the Canadian government to try and exercise an emergency clause that was in the license to be able to issue rights to another manufacturer that was capable of developing it. that clause wasn't actually used in the end, but through negotiations, the license was eventually transferred to Merck in November 2014. Merck continues to be the rights holder on this very particular RVSV vaccine. And NewLink, the company that obtained the initial license and did nothing with it, was paid $50 million for that. So good deal. And anyhow, ultimately, the story is a good story in terms of outcome. We now have a vaccine. It has regulatory approval in multiple African countries, as well as the FDA, Health Canada, European Medicines Agency, and so on. The initial sort of tranche of data, the first RCT, showed it was actually 100% effective. Real world data brought that down to sort of 97, 98% from subsequent outbreaks. But, the point is, this is a highly effective single dose Ebola vaccine that's very useful in outbreak response. We now actually have a second vaccine. It's a 2-dose regimen that is probably quite fine for communities that are at risk, or in other people who can sort of plan a little bit further. But we actually know that with the Canadian vaccine, even people who receive it, within 2 days of becoming, if they receive it 2 days before having an exposure and becoming symptomatic, even at that stage, it still has a protective effect. So this is actually an excellent vaccine that unquestionably would have saved lives in the West Africa outbreak had it actually been developed. But it was sitting on a shelf really for lack of a viable, commercial market to ultimately fund the R&D and get it to the finish line. And this is really sort of has been a real kind of tipping point, I would say, in our thinking. And I'm just going to switch gears here and say that this market failure really is a massive problem. These are graphics from the O'Neill report, which is a UK review on antimicrobial resistance, that really points to the fact that we're looking at millions of deaths from something like antimicrobial resistance by 2050, with multiple billions of dollars of impact on economies. And this is an area of investment that is really not attractive to venture capitalists. There's really very little private investment interest in something like antimicrobial resistance because it's not a profitable drug marketplace. Antibiotics are drugs that we typically take for a very short period of time, 5 days, 7 days, 10 days, right? You use them for a short period. Any new antibiotics that come onto the market are going to be used extremely sparingly, so that we don't generate more antimicrobial resistance, right? So, all these things start to sort of shrink the profitability. And so frankly, it's just not lucrative enough to attract very much attention. And so this points to like this ongoing reality. And again, this is something that Kish mentioned in his introduction, is that there's a significant disconnect between public health needs and the profitability of some of these drugs. And we see these market failures abounding, across multiple different pharmaceutical areas, whether that's pandemic preparedness. There's really no lucrative market for most medical countermeasures against infectious diseases until the point that they kind of tip and you start having thousands or hundreds of thousands of cases, right? I mean, you're otherwise who's the purchaser of these vaccines or new therapeutics or diagnostic tests? Neglected tropical disease, certainly, and as I say, antibiotics. And so that raises the question, well, okay, so who is actually funding the research and development into this? It's often public and philanthropic sectors that are at the forefront of research in drug development generally. There's good evidence coming out of the US over multiple decades showing that 100% of new drugs that have come onto the market have some form of public funding that's backing them. But certainly we know from Ebola that public funding contributed well over 73% of the funding into Ebola and other filovirus research over a 20-year period. And so, you know, we're encountering this problem very regularly, and I think, you know, people should be shocked, frankly, to learn that, you know, even for drugs that are discovered with public funds, a lot of these drugs ultimately end up priced out of reach of patients in low and middle income countries, but also increasingly in high income countries in Canada. There is no requirement that a recipient of public funds who uses that public funding to develop a new drug and bring it to market would then make that drug affordable and accessible to, you know, the same taxpayers who paid for some or all of the R&D. And so this is where we've been looking at things like global access licensing as a means of, you know, in negotiating earlier on in the R&D process for some form of affordability and accessibility measures, either through, you know, non-exclusive licensing. So, you know, maybe a generic pharmaceutical company has a license to manufacture drugs in low and middle income countries, and that sort of addresses some of the access constraints there. Or, you know, straight up sort of pricing structures that are baked in at the sort of earlier stages of drug development or at the point of shifting to manufacturing. So, you know, we're looking at some of these global access licensing provisions and how to actually make them into something that's tangible. So here in Canada, this is where we've ended up, is sort of realizing that you know, we need to have a better sense of drug development in our own backyard, knowing who's working on projects, so we don't find ourselves caught off guard as we did with the Ebola vaccine project. So over the last couple of years, we've been really canvassing across the country, trying to find researchers that are doing drug development work and figuring out how can we be a catalyst for these projects uh, when we know that MSF teams are going to need access to the final products if they, you know, are safe, effective, and actually make it through regulatory approval. Um, and so we've been working with Kish on the AMP-B development project. You know, it's relevant to MSF because we treat patients with leishmaniasis, but also we're interested in an oral formulation of amphotericin B because we use the intravenous formulation to treat cryptococcal meningitis, which is a complication of advanced HIV. But also there's other fungal infections. I think we should probably all be a bit more worried about fungal infections than the world seems to be. But anyhow, so the AMP-B project is of significant interest to us. We've been working with Kish on, you know, sometimes it's fairly basic things, making connections to either funders or Drugs for Neglected Diseases Initiative and so on, or supporting on research grants or providing letters of support to sort of demonstrate that this is an important project. You know, kind of trying to make sure that we're putting the MSF credibility to full use. Otherwise, we've been engaging with the Canadian biomanufacturing facilities, particularly around the potential for manufacturing monoclonal antibodies for infectious diseases. So you can see the sort of top opinion piece here is something that my colleague Adam Houston and I wrote in the Montreal Gazette at the end of last year. Canada, during the pandemic, built two public manufacturers in Montreal. They've produced precisely nothing up to this point, but have an operating cost of about $17 million per year. You know, we think that there's a public interest argument to be made here for putting them to use for manufacturing things for which, again, there is a market failure. And then we've been looking at other vaccine candidates, either from universities or from the National Microbiology Lab for Marburg or Ebola Sudan or Lassa fever. And so really trying to answer some of these questions here of, what role can we play in trying to be a catalyst for drug development, either as a connector or, a supporter in some way. But also, how can we work with technology transfer offices to try and facilitate some common sense access licensing provisions into tech transfer agreements, right? Like how can we help you include language to secure global affordable access or kind of enforceable registration of products in endemic countries early on in the licensing and R&D stage, instead of waiting for something to come to market and then being priced out of being able to purchase it, or having a pharmaceutical company not register it in a place where it's needed, right? Like, how can we actually negotiate that earlier on in the process instead of fighting about it later on, while patients are being deprived of treatments that they need? So, we've been trying to engage with members of parliament as well as senators. We've been pretty successful, I would say. You can see there's a report from a parliamentary standing committee here that agreed with us and included this exact recommendation around global access licensing provisions in a report in 2022. So, we're finding some resonance. It's just a matter of, I think let's put the rubber to the road. And so just, where do we go with this? I think we're facing an uncertain future of medical research and development investments. I'll just say I don't know what the NIH funding freezes in the States, for example, might suggest for the future of medical R&D. We'll see. But certainly the US has been a major funder of R&D for things like Ebola and other high consequence infectious diseases. NTDs are a huge area of need. We've invested quite significantly through the Drugs for Neglected Diseases Initiative and others, and that those investments have led to some real significant game changers. For example, this drug fexinidazole for human African trypanosomiasis basically changed the treatment course for this awful disease from a highly toxic, intravenous formulation that was cumbersome. It killed, I think it was somewhere around 1 in 5 people who received it. DNDI did the drug development on this oral formulation of another drug, fexinidazole, and has completely changed the landscape for how the disease is treated. We're also trying to push for shorter regimens for some diseases. As I was talking about, tuberculosis as a good example. We're an organization that's caring for people who unfortunately are often forcibly displaced or might have to flee because of violence or natural disasters or something. So if we can get people on a shorter regimen, that sort of creates a shorter window of time to get treatment underway and completed. It makes life a lot less complicated if you're in a refugee camp or in some other chaotic environment. And we're also always interested in greater temperature or thermal stability for different medicines and vaccines. The Ebola vaccine is a prime example of that. It needs to be stored at about minus 80 degrees Celsius. So it's quite impractical, but at the moment it's the best option. And then of course, as I say, pushing for some common sense global access provisions, which in our view should be standard in licensing agreements. I think it's reasonable to suggest that medicines that are developed with public funds should be affordable and accessible to patients who need them. In Canada, particularly if the Canadian government is paying for the R&D or manufacturing, but certainly in low and middle income countries. And I'll stop there. Thanks.
Thank you very much. Let me see if my video comes on. All right, here we go. I am alive. Thank you very much, Jason, for an outstanding presentation. And I think you bring up a lot of issues and questions that we need to do a deeper dive in. So thank you so much for your time. Um, Colleagues, it's a small group, and we do have some time for questions and comments. So I do see some comments in the chat, but you're more than welcome to unmute your mic and state your name and where you're from and ask Jason or myself questions. Unfortunately, Rich is getting off the plane in Rwanda, so he may not be able to answer, but Fahan could try to get those questions and she may be able to answer them. So any questions from any of my colleagues? Yes, Nancy, please.
Let me just get my... Okay, Jason, thank you for that excellent talk. Let me just get my video going here. Thank you so much for that excellent talk. And I just want to use this as a plug to reiterate what Richard mentioned at the beginning about the workshop that NGDI is hosting on March 11th, which is exactly around the issues you're talking about with global access and equity to drugs and what universities can do in terms of, like you said, standard licensing agreements. And it was fascinating hearing about all of these issues around patents and licensing and the market failure in vaccines. And I was just wondering about a couple of other strategies that I know have been used in the past, for example, like the medicine patent pool, and just wondered how successful that's been, because that is voluntary and it's not clear that always the best drugs will go into that pool. And the other one was the advanced market commitment that Michael Kramer had discussed. And I understand that was maybe working for a while and wasn't so successful in generating new vaccines. And so those are two I'd love to hear your comments on. And then I guess if you have time, you talked about the importance of U.S. Aid. And, you know, with this recent 90-day freeze on foreign aid that the U.S. president has just initiated. But then it was just blocked by a court. But we know that this kind of thing is going to happen again, and the impact that kind of reduction in foreign aid could have in terms of getting drugs and the impact on infectious diseases and so on. So over to you, Jason.
Yeah, okay. All right. So maybe I'll start with the advanced market commitment. In general, the advanced market commitment was this idea that if a bunch of donors came together and put a bunch of money on the table, the first one was for the pneumococcal conjugate vaccine. So childhood pneumonia has been the leading cause of death for children under the age of 5 for a very long time. A lot of that is caused by pneumococcus. And so there are vaccines that are effective against multiple serotypes of pneumococci. So those vaccines are very common in high-income countries. So basically any baby or older adult that you know, in Canada would at least be offered a PCV vaccine. But the price is very high. I mean, I don't know where it is right now, but it was a few years ago, it was well over $100 a dose in Canada and the US. So, you know, that's well out of reach for low-income countries, and you need 3 doses as a newborn. The advanced market commitment was basically this idea that if donors come together and put money on the table, you know, and demonstrate effectively that there is a market, you know, there's an advanced market, there are donors committing to putting money on the table to create this market, you know, would that then stimulate increased production from the existing vaccine manufacturers? And would they bring the price down to, you know, something that was more reasonable? And would that be enough to incentivize subsequent entrants to come onto the market? And so to be very honest, it's a mixed bag. It's certainly more successful now than it was at the outset. We were very critical of it for a few reasons. One is that the price that was set by the advanced market commitment was very high. I think it was $10 or $11 for the 3 doses, and there's good evidence that that price could be well below $5 and be profitable. So it was more than really double what it should have been for no clear reason. And so, when you're dealing with a finite number of dollars that are on the table, if you're paying more than double what you could be paying, then that's, you're only vaccinating half as many children, right? I mean, in very basic math. So the dollars weren't going as far as they could have been. And, Pfizer was the sort of predominant supplier of vaccines into the AMC. Pfizer is one of the most profitable companies on the planet. There's no reason why this needed to be the place that they were, sort of profiting, was basically the argument. The second is that the AMC was actually quite restrictive in terms of the number, or not the number, where people could be vaccinated. So if you were, if you were from Central African Republic, for example, or if you were whatever, if you're from Central African Republic and you were in Central African Republic, you could be covered by the advanced market commitment. But if you found yourself displaced in another country, you couldn't use the vaccines purchased through the AMC in that country to then vaccinate somebody from another country. And we were running into problems because we weren't allowed to procure the vaccines through the AMC in humanitarian emergencies. And we tried to use them in Greece, was sort of the classic example. And Pfizer tried to charge us 64 euros per dose instead of the, whatever, $7 or $10 that they were charging everywhere else. So, it was a bit of a mixed bag. It really didn't incentivize subsequent entrants into the market until the very tail end. So there now are, I think, 1 or 2 that came on. But our perspective was that there were obvious gaps in it, like there was no humanitarian stockpile, for example, that we could draw on in an emergency. So that was a gap that ultimately got fixed. The pricing was, really not negotiated as aggressively as it ultimately could have been. The price did eventually come down. It didn't totally incentivize new manufacturers to come online. So, I did a pretty mixed bag in my opinion. But it was the first sort of kick at this. So yeah, that's that. And sorry, I forget what your first question was.
With the medicine patent pools, how
Medicine patent pool. Yeah, so you hit the nail on the head. Again, it's a voluntary licensing agreement. That's always going to be the weakness of these things, is that ultimately it's up to somebody deciding that they want to participate. And the companies that license into the medicines patent pool. So the mechanism is basically, a pharmaceutical company who's a rights holder can issue a voluntary license to the medicines patent pool, set the sort of terms of that agreement, but then the MPP can license out to generic manufacturers who can then sell generic versions of that drug or vaccine in low and middle income countries. The gap that we see is in that middle income countries piece. Right. So there's several middle income countries that have very large gaps in terms of access to medicines, particularly for antiretrovirals and hepatitis C medicines and so on. Pharmaceutical companies increasingly view those as being profitable markets, so they're excluding them from the MPP licenses. So I think the MPP as a concept is great. There's no question that it's facilitating more affordable access to patented medicines through voluntary licensing schemes. But as long as this remains voluntary, you know, there's going to be companies that simply choose not to do it, and there's many companies that choose not to do it, and that's not the MPP's fault. The MPP works very well at what it does, but you know, if you can't get the inputs into it, then it's quite challenging, you know, to sort of use it as a mechanism for fully closing those gaps. So, yeah, I mean, I think the MPP is great for what it does,
And
but
we will, yeah, if I can jump in,
Thank you.
yep.
MPP will be at our workshop. Andrew Goldman has confirmed that he will
Oh,
be
great.
at our workshop, and in fact is providing funding
Yeah.
for our workshop in Vancouver in March, and
Oh, that's
so we
great.
can ask him himself. The other thing is the MPP has expanded to their work with universities, and as you know, they have just signed a lucrative agreement with UCLA, and UCLA is doing some amazing work in this area. So they've gone beyond the pharmaceutical companies and have gone right into the universities. And I
Mhm.
think there is now early discussions with us here at UBC as well. But we're looking at the UCLA model because that's quite impressive what they've done with UCLA.
Yeah.
So more to be had. Lamis, great, great. Thank you so much for coming online. So Lamis, question from you, please.
Thank you. Thank you very much. And thank you, Jason, for the beautiful talk. So just a little bit of background about me. I'm a researcher on NTDs, and I'm Sudanese who's currently displaced due to the war in Sudan. And one of the things that I wanted to ask Jason, it's something that we really now are observing in Sudan, is that many of the drugs are counterfeit or are of very low quality. So, for example, in some states, there's an outbreak of malaria, and patients take the medication and it does nothing. So probably, like, there is the drugs are counterfeit, probably. So I was wondering, like, does the MSF do anything to sort of try to tackle that? Because it is really a big problem, and it's just basically a waste of money. The patients will buy the medication, but then they're not effective. So I was wondering if there's any work done in this area.
Yes. So there's kind of two answers to the question. So one is, you know, the broader public health problem that you're describing. I'll just say I've done a lot of work in this space. I published one of the first case reports of you know, a death that we could reasonably attribute to a substandard antibiotics, ceftriaxone, in a child who had bacterial meningitis. And we've done some landscaping work. You know, this is me in my research life, you know, sort of trying to do some prevalence studies of substandard antimalarials and antibiotics and anesthetic drugs as well. So I'm very aware, like, this is a massive problem. You know, it's a massive problem that many places is poorly regulated and poorly controlled. And so on the sort of broader public health problem, it's not really a space that we're involved in an operational sense. At like the policy level, yes, but like we're not doing sort of prevalence monitoring or anything like that. The way in which we are engaged in it is that we manage all of our own supply chains. So coming back to one of the things that I said in my presentation, so you know, we purchase all of our own medications. And sometimes the most useful thing that we can do in a disrupted health system is to provide access to our, you know, emergency supply chains. Like our logistics network is designed to be flexible, to, you know, scale up and sort of respond to acute emergency needs. So in some places, you know, the best thing we can do is to procure and then provide donations of emergency medicines. Now we can't do that everywhere because that's not what we're set up to do. Is we're not set up to supplement like every pharmaceutical supply chain on the planet. But sometimes that is what we would do. And so we do have regulatory pharmacists that work for us specifically. So depends on who we're purchasing from. Like, if it's a company that's, in a country with a competent regulator, there's sort of international standards for what this is, then, we would accept that. But sometimes we do just send a regulatory pharmacist to actually go inspect a manufacturing plant before we would make purchases from it. So, we're sort of controlling that problem on our own end as best we can. But these are very profitable, counterfeiting markets as well. So, yeah, that's kind of the probably the best answer I can give you.
I think Lamis is a rock star. We met her at the Global Health Conference in Vancouver. She gave an amazing talk. So Lamis, thank you for coming on. We really appreciate it. But she brings up an excellent point there, Jason. I mean, in India for many, many years, there was a lot of substandard manufacturing going on. And luckily, things have started to change in India in the last 15 years. Manufacturing on the ground there has gotten a lot better. And there's models now that could maybe be used in other countries. But you guys are both correct. This is a serious issue. And we're finding I'm spending more time on scale up manufacturing issues than I am on basic science these days, trying to understand that. So these are very good points. Colleagues, we only have a couple of minutes left. There are a couple of comments in the chat about things that people are doing and so on. So anybody else, please, I know this is being recorded, but please feel free. We got a couple of minutes left, or any other question. Poor Jason's taking all the questions because Rich is in Rwanda, but thank you, Jason, for doing that. Any other questions or comments from our colleagues here? Okay, not hearing anything. I want to thank you very much for coming. I mean, for everyone's a bit different time, and really appreciate it. And I would say definitely quality over quantity. It doesn't really matter how many people come; it's the quality. I think the talks were both excellent, and the dialogue and questions were great. So, Jason, thank you very much for coming, willing to speak. And Fahan, please thank Rich. Rich, as I say, got called away quite quickly to go to Rwanda and was still willing to put together a talk for us. So we really appreciate that, and so on. And then thank all of you. And I hope we can continue this dialogue and engagement. I will say I used to be a political man. I'm not political much anymore. I'm more of a half glass full guy. We will make it through. That's all I'm going to say. So thank you, everybody, and have a very good evening or morning or middle of the day, depending on where you are around the world, and have a good night. So take care, everybody.